have is a request for bill introductions. Do we have any? Seeing none. Okay, today we'll have a briefing on foster care case plan tasks and permanency outcomes from Josh Luthi and Mental Health Substance Abuse Initiative and Healthcare Access Improvement Program by Heidi Zimmerman. So I guess first we'll have Josh up. Josh, thank you for being here. Welcome to committee.
Thank you, Mr. Chair and members of the committee. So just for the record, my name is Josh Luthi, and I will be presenting an audit looking at Kansas's foster care system. I think you've probably got a few of our reports in front of you. So the one I'm talking about looks like this. It says reviewing foster care case plan tasks and permanency outcomes on the cover, if you'd like to follow along as I talk. So kind of a brief roadmap here. What I'm going to do is start by talking about the two audit questions and their very high-level, brief answers. And then I'll work through the report in a little more detail. And as I go through the report, I will try to keep you posted on what page I'm on in case you'd like to follow along. So first, the audit questions and their answers. The first question asked whether the tasks in foster children's case plans seemed reasonable and relevant to their successful reunification with their families. It also asked whether those tasks were being completed by children's parents. And we found parents' tasks were generally reasonable and relevant, and that parents generally made progress on or completed their tasks. The second question asked whether outcomes for children in foster care, such as whether they reunified with their families or were adopted, varied based on demographic factors. We found outcomes did vary based on the 4 demographic factors we looked at. Those factors were race, ethnicity, age, and sex. I'll discuss the specific effects of each factor later on. So now then, getting into some of the details in the report related to question 1. I'm going to start out with some background information, and that's going to be primarily on pages 3 and 4 of the report. So while kids are in the foster care system, they and their families receive case management services. DCF contracts with 4 private case management providers for those services. One of the things these providers do is develop case plans. And case plans, among other things, document the way in which a child is trying to leave the foster care system. So, for example, reunification might be a goal a child has, and that's when they go home to their family. This is the preferred way for kids to exit the foster care system, and it's also the most relevant outcome for this first question here. So that's really what I'm going to be focusing on here for this first part. But there are 3 other outcomes. Those are adoption, guardianship, or another planned permanency living arrangement. Another thing the case plans should do is include tasks that people like a child's parents need to do to help the child achieve their permanency goal and leave the foster care system. Lots of different parties, including the case management staff, parents, children, and judges, might weigh in on the tasks that are assigned. And to be clear, parents aren't the only folks who can have tasks, but because tasks assigned to parents are the focus of this audit, they're really the only thing I'm going to be talking about here. And finally, when I say parents, I'm referring to whoever it was the child was removed from. So this is generally a child's biological parent or parents, but in some other cases, it could be somebody like a grandparent. So earlier, I told you we found parents' tasks to be generally reasonable and relevant, and that parents made progress on or completed their tasks. Getting into the details of that, though, first regarding the extent to which tasks were reasonable and relevant, we reviewed tasks from 48 children's case files to see whether the tasks assigned to their parents seemed reasonable and relevant. We reviewed a total of about 670 tasks assigned to parents as part of this work. Figure 3 on page 7 shows the number of tasks assigned to individual parents in the cases we reviewed. As that figure shows, we didn't think parents were assigned an excessive number of tasks. On average, a parent was assigned 11 tasks across the life of their child's case. Continuing then on the bottom of page 7, we found that 90% of the tasks we reviewed seemed to be reasonable and relevant to reunification. And for our purposes, we thought tasks were reasonable when they reflected appropriate expectations and weren't excessive or overly burdensome. We thought tasks were relevant when they related to why the child was removed from the home or other risks to the child's safety. But as we note on page 8, about 10% of the tasks we reviewed did seem unreasonable or irrelevant. About half, so that's roughly 70% of the tasks we reviewed, just in terms of raw numbers there. So about half of those 70 tasks related to parents' income, housing situation, or drug testing. For example, in one case, we saw a parent have a task to submit to drug testing, but the case plan documents themselves said that nobody had any concerns about the parent's substance abuse. So it's really unclear to us why the parent had that task. It seemed irrelevant to their situation. The other half of the tasks that we took issue with were similar, and they seemed to address problems that just didn't exist. So because tasks addressed problems that didn't seem to exist, they often weren't things that parents needed to do something about, so to speak. So by way of another example, we found that some tasks related to safe and stable housing or income to be irrelevant in some cases. That was because the parents in those cases already appeared to have those things in order, so there's really nothing for them to do. But that's not to say that certain tasks can't have detrimental effects. For example, unreasonable or irrelevant drug testing could be a problem. Drug tests can be difficult for parents to get to if they have a job or if they lack access to transportation. And we saw that courts sometimes required parents to pass drug tests before they could visit with their children, so those sorts of things could create unnecessary barriers between parents and their kids. Before I move on, a couple caveats here. First, the cases we reviewed came from a non-random selection, so our findings are not projectable. And second, we did use our professional judgment to decide whether tasks were reasonable and relevant. There aren't terribly clear criteria for evaluating these things, so there is some subjectivity involved. And then second, kind of talking about whether parents completed or made progress on their tasks. This information begins halfway down page 9. We found parents generally did make progress on or complete their tasks. Parents completed at least some of their tasks in most of the cases that we reviewed. And then in some other cases, parents made progress on their tasks even if they weren't complete at the time of our review. And in some cases, that was because we were looking at cases that were currently open, so parents and their kids were still working through some of these things. I'd also note here that parents didn't have to complete all their tasks to reunify with their children. And there were at least 2 reasons for this. First, some tasks were ongoing tasks that might not have a firm completion date or might extend beyond the point at which a parent reunifies with their child. For example, if a parent has a task to attend therapy, the parent might continue to attend therapy after they've reunified with their child. And second, according to the case managers and judges we spoke with, a parent doesn't necessarily have to complete all of their tasks to reunify. They told us that reunification may be appropriate when parents have addressed safety concerns, have a safe and stable home, and have shown behavioral change. But at that point, I would kind of question, if some of those tasks don't need to be complete, are they really relevant to reunification? In some cases, I think that's probably not the case. So that's going to conclude my comments on question 1. Moving along then to question 2, which, just a reminder, was about the relationship between kids' foster care outcomes and their demographic factors. I'm going to focus mainly on what our analysis showed here, but there is more detail in the report, including stakeholder opinions on why we may have seen the relationships that we saw. First, though, a little more background information. That's going to be on page 11. We looked at outcomes for all children who entered the foster care system between 2012 and 2020, and who left foster care by January 2021. Our analysis included about 28,000 cases, but our analysis did not include children who were still in foster care. And for this question, we focused on more than just reunification. That was what question 1 mainly focused on here, but here for this analysis, we looked at all the ways in which a child could leave the foster care system. Those possible outcomes are on page 12. You'll see there were 6 of them. They were reunification, adoption, guardianship, emancipation, transfer to another agency, and this other category. I will say now we don't discuss that last other outcome as part of our findings, and that's because we weren't confident our analyses accounted for enough information to really fully evaluate that outcome. Also, a caveat before I get into what our analysis showed, We cannot say exactly why there are relationships between the demographic factors we looked at and certain foster care outcomes. It could be that demographic factors like race do directly affect a child's outcomes. It could also be that some other factor that we didn't look at, like income, is linked to one of the demographic factors we did look at, and it's actually that other factor that's driving the outcomes we saw. So that's to say there's probably some more work to be done in this area to really more fully explore what it is that's driving kids' foster care outcomes. But with that said, if you would join me on page 14, I'll talk about the relationship between kids' races and their foster care outcomes. So figure 6 shows how children's outcomes compare based on their race. For each demographic factor we looked at, we did have to use one demographic group as a baseline as our point of comparison. For race, white children were our baseline, and that's because they represent most of the foster care population. Figure 6 then shows how outcomes for children of other races compared to white children. But based on this comparison alone, so this is just the descriptive statistics, we can't say whether children's races cause the differences that we see in that figure. And that's because factors beyond race could be influencing children's outcomes. So for example, let's say hypothetically black kids just happen to be older when they enter the foster care system than white kids. It could be their ages that drive their outcomes rather than their race. So to see whether it was specific demographic factors, like in this case race, that influenced children's outcomes, we did a series of regression analyses. And the benefit of these analyses were that they let us isolate specific demographic factors to see what their effects were, kind of holding everything else constant. So we discussed the specific effects of race on children's outcomes on pages 16 through 18. To kind of briefly summarize, we found that relative to being white, being black reduced a child's odds of reunifying with their families or entering a guardianship. And by contrast, being black increased a child's odds of emancipation or being transferred to another agency, like the Department of Corrections. We also found that American Indian children were less likely to reunify with their parents and more likely to transfer to another agency than white children. I note here this is likely because of the Indian Child Welfare Act, which requires cases involving American Indian children to be transferred to a tribal court in some instances. On pages 18 and 19, we discussed the effect of ethnicity. Another quick note here, ethnicity refers to whether a child is Hispanic. As figure 8 on page 18 shows, relative to being non-Hispanic, being Hispanic increased a child's odds of reunifying, but decreased a child's odds of being adopted or emancipated. On page 20, we discussed the effects of age. Here, I would mainly refer you to figure 9. The figure shows how often children experienced outcomes based on how old they were when they were removed from their homes. Our analysis showed that children's ages had statistically significant effects on their outcomes for all of the outcomes pictured. So for example, being older decreased a child's odds of reunifying or being adopted, and it increased their odds of being emancipated. On page 21, we discussed the effects of sex on children's outcomes. We only identified one significant relationship here, and that was that being female decreased a child's odds of being transferred to another agency relative to being male. Finally, on page 22, we note black children were overrepresented in the foster care system and among children still in foster care. So that'll conclude my comments on question 2. We did not make any recommendations as part of this audit, and at this point I would be happy to stand for questions.
Very good. Committee questions. Representative Lynn.
Thank you, Mr. Chair. You were looking at the race of the child. How did the race of the foster family affect whether or not they, I mean, did you try to put similar races together is what I'm asking.
No, we didn't include additional data like the race of the foster family in the analysis.
Okay, thank you. Thank you, Mr. Chair.
Representative Clifford.
Thank you, Mr. Chairman. A very nice report. I'm accustomed to science, which uses p-values and statistical significance. Is there a similar analysis here, or is there a social p-value I'm not aware of?
I believe we're using a p-value of 0.05 here, and all of the statistically significant effects I discussed in my overview, they were statistically significant at that level.
Thank you, Mr. Chairman.
Representative Helmer.
Yes, I know you said that the discrepancy that you were talking about children that died. Did you include, and I know it's not in this book, but did you track children that were missing and murdered
No.
that you have somewhere else? Okay, thank you. Very good information, though. I appreciate it. Thank you.
Any further questions? Representative Ballard.
Thank you, Mr. Chairman. I apologize for being late, but we had leadership. And I came in on this section, so I'm asking only about the section I came in on, to make sure it's not a repeat. Okay, so you indicated that there are more white children involved in foster care, right? Okay, but on page 22, you say Black children represented a larger share of foster care cases than expected, and that was based on the census. So when I'm looking at this, they stay longer and they basically don't get out of the system is what I'm really seeing here, right?
I think that is a reasonable interpretation.
Okay, that's what I was looking at. Well, about 6% of Kansas population, but Black children account for about 12% of it. By contrast, they were 2 times more likely to be removed from their families than white children. This corroborates. Okay, what did you find out? Is that because you try to place them in the same race in foster homes as they are? I mean, is that a priority first, and then therefore, if not placed, then they don't get placed?
We didn't look into maybe what was causing this to happen. I know we did speak with some of the case management providers, and I think at least one of them identified some challenges associated with recruiting Black families for foster care. So I can't say whether that is or isn't a problem, but it may well be a contributing factor.
That's good. Thank you. Thank you, Mr. Chairman.
Representative Lynn.
Thank you, Mr. Chair, and that's to follow along. That's kind of what my line of thinking was. Do we see that there's more success when a child is placed with their race with the foster family's race? I wonder if there'd be difficulties.
Can I answer that? Okay, because I've worked in that area. Actually, it doesn't, there's very little research to really say that if you are Black or you're Hispanic or Asian and are placed with one, that it's any better. What really becomes a contributing factor is what you may have in common in terms of what you do and everything else. But the preferred one would be to place them with an identity that they can identify with, an entity, I should say. In other words, if you're Black, you would have more in common. Maybe you'd feel more comfortable in everything else. But in lieu of that, you'll take another good, family in order to help, because then you're minus that factor. Does that make sense? Thank you.
Very good. Committee, further questions? Representative Howerton.
Thank you, Mr. Chair. On the task, was there any kind of a study on how much, like the unreasonable task, how much time that added to kids in foster care? And then my second question would be, who is in charge of assigning the task? Is it the social worker?
There could be a variety of folks responsible for assigning the tasks. Let's taking your second question first here. The case managers are going to be the ones who lead the case plan development process. They should be getting input from parents, kids if they're old enough, and then potentially other parties like attorneys, guardians ad litem, lots of folks. Judges at case plan hearings might also weigh in on case plan tasks. So, if I had to pick the top 2, I think it would be judges and case managers that are primarily responsible for this stuff, but a lot of people could identify possible tasks.
And then how much time did it add to kids being in foster care for the unreasonable task?
I don't know that I can answer that question, but on pages 8 and 9, we do talk about how the presence of these tasks seem to have affected, or rather not affected, whether families went on to reunify. So I can't say that the existence of those tasks didn't delay reunification, but it didn't seem to really stop families from reunifying.
And then just to follow up with that, are these findings going to the case managers to maybe reassess some of the tasks they're giving?
Yes, the results of this audit, they were communicated to all 4 case management providers.
Very good. Committee, further questions? Representative Donahoe.
Thank you, Mr. Chairman. I thought about this last year when I heard social worker comment, but they're talking about relationships that the child had. I think the child committed suicide. What relations? And they checked all kind of relationships, father, social worker, et cetera, et cetera. And my question to myself was, what about the relationship to God? Is there any evidence, or is there even a study on the child, their relationship to God, their faith involvement, anything like that?
No, we didn't.
Okay. I just think that since faith is such an important aspect of this, I'd be curious to know, those children that have a deeper belief than others, if it affects them or their recovery, their involvement, their assimilation. Anyway, thank you. Thank you, Mr. Chairman.
Any further questions? Okay, very good. Thanks, Josh. Very good information to know, committee. This is just kind of our deeper dive into information, and maybe at some point in time we'll be able to make some recommendations that'll make things better. Okay. That being said, Heidi, are you ready? Thank you for being here very much. We're looking forward to your report.
Here we go. All right. I am Heidi Zimmerman. I'm a principal auditor at Legislative Post Audit. I believe you have 2 audits still in front of you. Mr. Chair, which audit would you like to hear first? Okay. I guess we'll start with mental health. All right, so this audit was a 2-question audit, and I'm going to start obviously with question 1, and it's listed on page 1. So what practices or programs do state-funded mental health and substance abuse providers report using, and how well do they appear to be working? So the short answer to that question is that Kansas providers reported using many evidence-based programs and practices, but data limitations kept us from assessing how well they are working. So I'm going to give you just a little bit of background first, and then a little more detailed answer to that question, and then I'll move on to question 2 as well. So individuals without private health insurance can seek treatment through a number of state-funded programs. So there are 4 state agencies that oversee a variety of programs that pay for individuals to receive treatment. The Department of Health and Environment oversees the Medicaid program, which pays for certain substance abuse and mental health treatments for eligible individuals. Department for Aging and Disability Services, or KDADS, oversees the Substance Abuse Prevention Block Grant and the Mental Health Block Grant, which are both federal funds that provide treatment to eligible individuals. KDADS also oversees a state-funded treatment program for individuals who've been convicted of a 3rd or subsequent DUI. And then KDADS also oversees the state hospitals and the community mental health centers. The Kansas Sentencing Commission oversees the state-funded treatment program for individuals who have been convicted of certain drug possession crimes. That program is also known as Senate Bill 123. And last, the Department of Corrections oversees state-funded treatment programs for prisoners and parolees. So an individual who qualifies for state or federally funded treatment can receive it from an approved provider. The state typically licenses providers to provide services to people who qualify for a specific program. So for example, the Kansas Sentencing Commission has approved 131 providers to provide services to Senate Bill 123 offenders. And those seeking treatment under Senate Bill 123 must receive services from an approved provider. Across all the programs, approved providers include a network of approximately 200 private, public, and nonprofit providers. So on page 4, we start with some of the details of question 1. Just a reminder, Question is, what programs and practices do state-funded mental health and substance abuse providers report using, and how well do they appear to be working? State law and regulations do not require that providers use any specific programs or practices. However, licensing requirements may require providers to use some specific practice. For example, providers approved through the Sentencing Commission must use cognitive behavioral therapies. Within those limits, providers then determine what programs or practices they will offer to their clients. We talked to 23 providers to collect information on the types of programs and practices they use. We selected the providers to get a good cross-section of all Kansas providers in terms of location and size. However, our results are not projectable because we did not choose these 23 randomly. The 23 providers we talked to reported 95 different practices or programs that they use to treat mental health disorders or substance abuse disorders. We evaluated 11 of the 95 programs or practices that were most commonly reported across those 23 providers to determine if the research suggested that they were effective. Those 11 programs are listed on page 6. So for each practice, we reviewed the existing national and international academic research to determine whether that practice was evidence-based. And we made that determination based on the totality of all the research that we reviewed. So that figure on page 1, if you look all the way to the left, you'll see little dots. So the more dots that are filled in, the stronger the evidence was that that program or practice was effective. So 8 of the 11 practices had moderate to strong evidence supporting their effectiveness as a treatment. 1 treatment, which was cognitive behavioral therapy right at the top, had strong support for its effectiveness. And then 7 practices had moderate support. For 3 of the practices we reviewed, research found either weak evidence of effectiveness or was inconclusive. I should note that nearly all of the research that we reviewed noted that there were additional questions that needed answered. And most researchers urged additional research to gain more clarity about what works best for different populations of people. We also talked to the providers about the challenges they faced. Many providers that we talked to reported that a lack of funding made it difficult to provide services to more individuals. Specifically, providers noted that Medicaid rates have not been increased since the early 2000s. Many providers also reported difficulties in finding enough qualified staff. Some said that licensed clinicians were especially difficult to find. Part of this objective was to assess effectiveness of state-funded programs, and here's where we ran into a few problems. So first, determining what a successful outcome is can vary based on the person and their condition. There is no one universal outcome measure that makes sense for everybody. Some mental health conditions are lifelong conditions, so an occasional relapse is likely, but that does not mean their treatment didn't work. Individuals seeking mental health treatment or substance abuse treatment tend to be a transient population as well, and it can be difficult to track those individuals for more than a very short amount of time after they finish treatment. So as a result, assessing a long-term outcome is simply not possible. But the most practical obstacle that we ran into was that none of the 4 oversight agencies maintain complete or reliable data for all the individuals who receive state or federally funded treatment for mental health or substance abuse. The providers also do not consistently collect outcomes data. So as a result of these things, we were not able to determine the effectiveness of state-funded treatment. The second question begins on page 8. That question was, how does state-funded mental health and substance abuse programs in Kansas compare to those in other states? We used 2019 data from the Substance Abuse and Mental Health Services Administration, or SAMHSA. SAMHSA is a federal agency that gathers data through a periodic survey of all mental health and substance abuse facilities. We compared Kansas's results to 5 other states that are like Kansas in terms of population and median household income. We chose Idaho, Iowa, Nebraska, Nevada, and South Dakota. And we compared the kinds of programs and practices the providers in those states use compared to the programs and practices that Kansas providers use. What we found was that Kansas substance abuse providers, the practices they used were generally like the practices in other states, but there were a few exceptions. So for example, Kansas had fewer substance abuse providers that offered hospital inpatient services. When we looked at Kansas mental health providers compared to the 5 other states, once again, we found that the Kansas providers were very similar to the other states. But again, there were a few exceptions. So for example, Kansas had fewer mental health providers that offered trauma counseling. But on the other hand, Kansas had more mental health providers that offered services such as telemedicine. Last, we again were not able to compare outcomes in Kansas to other states because much of the Kansas data is either missing or unreliable. We didn't make any recommendations in this audit, but that concludes my presentation. I'd be happy to answer any questions.
Very good, thank you. Committee questions? Representative Vaughn.
Thank you for this really comprehensive presentation. Thank you, Mr. Chair. In the beginning, you gave an example of certain programs that require the cognitive behavioral therapy practice. And since that was at the top of the most evidence-based practices available, I was wondering like what percentage of programs require the cognitive behavioral therapy, and just generally more interested in trends with that specific therapy. Thank you.
The Sentencing Commission does require any provider licensed to them to use cognitive behavior therapies. I believe Department of Corrections also requires that for at least some of their programs. Of course, KDHE doesn't require any sort of particular practice. They just if the physician accepts Medicaid, that's all that the KDHE is involved in. KDADS, I'm not sure what KDADS requires for their block grant providers.
That's helpful. Thank you. Thank you, Mr. Chair.
Representative Lynn.
Thank you, Mr. Chair. I remember seeing this last year, and I guess I'm sorry, I missed that part. Was this updated since last year? Or is this the same?
No, we released this in August, and
okay, then maybe I saw another one. I just remember thinking that the peer support, the strength of evidence for peer support is very low, and it seems like we hear in like our mental health committee that the importance of peer support. So I guess I would wonder what those 6 providers who do offer that, what their thoughts were on that, because I would think that that would be a program we want to make sure doesn't end. I don't know. Is there any more detail, I guess, about some of those results?
no, for these, what you see over on the right-hand side was the number of providers who told us they used them, and then just our kind of totality of research. I know peer support was one of those programs that the researchers who were doing the work did note a number of times that it needed more research. It was comparatively, I think, a newer intervention that's being used, and it just needed more. And a lot of those researchers were urging just more research to try to understand, especially what population might benefit from that versus other populations that might not.
That's what I was thinking too, is depends on the population. So thank you, Mr. Chair.
Representative Reeves.
Thank you. I'm going to go a little further than what Representative Lynn was asking, because I think she's on the right track with some of this. So just so that I understand, case files were not studied, I mean, to see the effectiveness. This was just based on research, on what was found regarding research.
Correct. We just looked at the research to understand whether or not the research even supported whether the program was effective or not.
Strength-based case management is the brainchild of KU School of Social Work. So there should be tons of research on that. I'm surprised that there wasn't enough that was found there. Same thing with peer support. They were a big proponent of that. IDDT also for substance use, and this is it's you know what it says, it's great for both who are duly diagnosed, do you have a mental illness and a substance use disorder. So I'm just, in trauma-informed care, it's the same thing. There is lots of research on all that. So I'm really surprised that there wasn't enough research that was found. And I think, you mentioned something about looking further into the research and seeing how this is effective depending on the specific population. And I think that's where you're going to see a flip side, where the last three noted here are used the most and is the most effective for those who have a severe and persistent mental illness. So
I think
to do more research on it.
I think the issue here was not that there was not enough research, but that in some cases the research that existed was inconclusive. There just was no answer. In other cases, like the strengths-based one, there actually was a fair amount of research on strengths-based, but most of it was of just simply very poor quality. The quality of it was not good enough for us to make a judgment on. And so until the quality of the research improves, we just didn't make a judgment on it. But it wasn't so much that there was no research. We're just waiting for the quality of the research to improve.
SAMHSA has, all three of these last ones are all evidence-based practices under SAMHSA.
SAMHSA, under their own criteria, they may do that. So we looked at more of the totality. We did consult SAMHSA on some of these. And again, it wasn't that there wasn't anything, it just that there might have been concerns about it. It was inconclusive. So inconclusive doesn't mean positive or negative. It just means right now we don't know. And so, as I said, the strengths-based one was just simply a quality issue. So, but SAMHSA does have a wealth of information.
Thank you, Mr. Chair.
Representative Ballard.
Thank you, Mr. Chairman. I'm on page 7, and I was looking at many providers report a lack of funding and staff shortage hindered their ability to provide mental health and substance abuse. And when I'm looking at that was the Medicaid rates. We have heard that before, and we continue to hear this, and I think Chairman Carpenter and myself and others have tried our best to try and increase that. But when we look at it, Medicaid rates have not been increased since the early 2000. So that says roughly we could be 15, 16, 17 years without an increase. And we know that there's very little that happens in the medical bill that's not increased. I know when I go to the dentist, my rates go up. I also know that my copay goes up and everything else, but yet we look here and I come from a medical background, so we look at this, so I just think that that's interesting for us to note. And also, they talk about the lack of Medicaid expansion, which is such a controversial issue here in the legislature, but nevertheless, it's always mentioned repeatedly. The other thing that, do you have any comments on that? No, okay. The other thing I was looking at that we're very proud of that maybe the new members don't know about Osawatomie. We closed it in 2015, and over 2 years ago, we asked for a comprehensive plan of how they could reopen it for voluntary, because it was only involuntary in court orders or whatever. But we're looking at it. Some of the same problems impose a moratorium because of insufficient space and staff. We were going to open in October. We weren't able to open it because of insufficient staff. And the space we did have, but not staff. So that's another area that you find out any more about, especially the lack of transportation for rural providers? Was there any other, or what specific questions might you ask about the transportation?
We simply asked them about what kind of challenges that they faced in providing services, and then let them kind of direct where that went. But the rural providers especially talked about a lack of transportation. Out in western Kansas, there's almost no public transportation. There's no busing systems. Those small towns maybe don't even have a taxi service. There's nothing. And so if you don't have a vehicle, Getting to where you need to be is very difficult. Added to that is there aren't a lot of providers out west either. And so not only maybe you don't have a car to get to where you need, but where you need to go might be 30, 40, 50 miles away. And the combination of those two things can be very difficult.
Very good. That's something I think we should really keep in mind because, you know, that's how I believe because of COVID, telemedicine has become a little more prominent. But on the other hand, you have to make sure that telemedicine is secure. And there's always a stigma attached to that. But thank you for the report because I don't know what we can do about transportation. You know, locally in Lawrence, we have Burt Nash, one of the largest CMHCs, community mental health centers. And for some cases, we have a transportation problem. They can't get there, but they do have a bus service, which we had to fight for years because most people have cars. And then the other was we have like vans, and we have kind of arranged that if someone can't go, we can go and pick them up, and we have the insurance liability and everything else. So I just wanted to draw this to our attention because sometimes even though we have the money and we provide the services, if they can't get there to it, then what do you do? And I'm looking at the doctor over here and he's going, yeah, that's a problem. So thank you very much.
Very good. Committee, further questions? Representative Donahoe.
Thank you, Mr. Chairman. This is basically for you, since I know you've just been sitting over there, and I give you something to do now. So anyway, it says we're not able to compare outcomes on other states because Kansas is not reliable. Has the powers to be, has anybody discussed this? I know this came out in August of 21, but is there any plans to upgrade, to do anything to put us in a position where we actually can get outcomes that are reliable that we can, you know, to compare to other states?
Well, I think that it's very realistic that those will be part of our committee recs when we meet with KDADS this year.
Right.
So we don't have the authority over the Sentencing Commission or the Department of Corrections in this budget.
But that's what I mean is, can we in the committee make these recommendations, at least to where we can get to the point where we can compare, hopefully, results to see where we're at?
I think that's a great recommendation. Look for it. So, any further questions?
Thank you, Mr. Chairman.
Sure.
And I won't bring anything up again.
I think those are very good. And I think that's the embodiment of what this committee does, is we hear this evidence, and that's how we do our committee recs. And that will be one of them. I did, matter of fact, I wrote that down right here. So one thing that I wanted to visit with you about, you studied the other states. Did they have a better data collection for this kind of stuff, or are all states struggling with this? You know, I mean, you're comparing 5 other states, so were there any insights that you gathered from that?
The data from Kansas as well as the other states all came from SAMHSA. So all of they all require the same things because they're all submitting data to the same system under the same set of rules. From that perspective, you know, it's nice, consistent data. We did notice that some states did have more missing data than others. We had a lot of missing data. So there was some inconsistency there. In terms of reliability, though, whether the data that was in the system was correct, unfortunately, we really couldn't evaluate that adequately to see whether other states also have trouble getting data, you know, inputted into that system with some reliability. But we did see some other states with missing data. And so I can say there's at least some problems in other states as well. I don't know if they reached to quite the level of problem that we saw in Kansas.
Well, Megan, is Matt here? Is he on board? Matt, this is kind of for you. Can you look around? Matt's our KDADS guy. So, Matt, can you look around and see if there are some states that have effective data collection for us?
Mr. Chair, can you hear me?
Yes, we can hear you.
Yeah, I can take a look and see what I can find for you.
Yeah, you know, I always don't want to reinvent the wheel. When another state is successful at it, we can just steal it from them, for lack of a better word. I'm not very politically correct sometimes, but that is something. But one thing, and I'll get to you in just a second, one thing I want to mention too is, and I think the Mental Health Modernization Committee met on quite a bit on this and topics and stuff. And one of the things that I think that we have coming online here in the next year probably is the CCBHCs. And I think they'll do a lot better job in this arena. And for some of us that have been involved on the Mental Health Committee and the Modernization Committee, I think this is precisely what that is for. I'm looking forward to getting that online and trying, but, you know, for you that have been around me, I've harped on data collection for, you know, because outcomes are so hard to gather, especially on mental health or substance abuse. And the reasoning you just said is classic, is because, you know, we get these folks in the system and they're there for a month or two and then they're transient and, they've had their medication and they're excellent, and as soon as they're off their meds and they're gone. And so it's very difficult. And I'm not making any excuses. I'm just stating fact about that population. So with that, Representative Ballard.
Thank you, Mr. Chairman. I just wanted to finish the reason why I was talking about Osawatomie, and I realized I left the important part out. I wanted to tell you that we are actually scheduled to open January 2022. You know, so October wasn't possible, but they were looking at January, so now are we still on schedule? But that's the good news. As long as their space that they do have and the staff that they do have is not full, then they can come in voluntarily. Remember, we just don't have that many places that people can go commit themselves. Hospitals don't. Even in Lawrence, Kansas, we had a wing, we closed our wing. Now we have opened 4 beds and one half of a wing in case, you know, emergencies that come in, that it can happen. But I'm just really excited about that because we asked for it and we know that's the only really place we have in the state. So we're hoping that people have that opportunity to receive those mental health services. But that's what I wanted to say, that it's coming online, and I forgot to even say that. So thank you.
And since they closed it in 15, when I and Representative Ballard were here, I'll never forget that. I had to cough up $9 million to subsidize the budget that year because we were closed. No. But this committee had to cough up $9 million to subsidize the budget.
There's a difference, we'll find out.
And we didn't have $9 million at that time. It was tough times here. So it was very difficult. Since then, we've probably spent a total of about $20 million, I think, just off the cuff, remodeling it and opening it for certification. So, and we've been on to it. It was supposed to open last spring.
Yes.
And then it was in the summer, and now here we are. So it's been a long process.
Yeah, Mr. Chairman, the other thing we might add that we'll find out later on is the main difference at 9,000 is between certified beds and licensed beds. Yeah. And so that becomes a big difference, you know, as to what we can have.
Exactly, because those beds that were closed were Medicaid beds, and the federal government was paying 60% of those. And then all of a sudden we went to the state paying the full bill. So tough times. I'm looking forward to better times when it comes to that. Well, very good. Committee, further questions? Representative Donahoe.
Thank you, Mr. Chairman. I imagine there's private entities that offer some of these services out there that kind of compete with this. Would that be correct?
Yes, there are private facilities.
Is there any way to access if they have data?
We wouldn't have access to the private data unless they receive Medicaid or something like that, then we would have access to it. But a private facility that doesn't accept Medicaid or any state-funded treatment, we have no authority
Right, but I'm not thinking so much of authority, just as general information that they might put out based upon their outcomes or something like that, whether that would be available. So when he's looking for data to see if there's any private data out there, and the reason I think it could be important, because it gives us a target or something to maybe shoot at to say, well, this is what's happening out there just till we get more data. Just a thought. Okay, thanks. Thank you, Mr. Chairman.
We didn't talk to any of those private facilities, but you might be correct that they would have a model or something that could be stolen in Representative Carpenter's words.
Matt, I know you're still on there. Can you kind of check around on that issue too and see if we can glean some data from those folks?
Yeah, I'll see what I can gather around for you.
Very good. Any further questions? Very good. On to the next one. Thank you.
All right, on to Hcap. All right, this is another 2-question audit. So the first question is on page 1. It's what Medicaid services are generating the bulk of payment distributions to non-hospital providers, and what are the add-on percentages for those services? So the short answer to that question is that in 2019, the top 20 procedure codes accounted for 74% of the total Medicaid payments to non-hospital providers. Again, I'm just going to give you a little bit of background on Hcap and then talk about question 1 in a little more depth, then move on to question 2. So in 2004, the legislature created the Healthcare Access Improvement Program, also called Hcap. The purpose of Hcap is to increase the number of providers who participate in Medicaid by increasing the reimbursement rates for those providers. The idea is that if more doctors participate, then Medicaid beneficiaries may have better access to healthcare services. Under state law, Hcap requires most Kansas hospitals to pay an annual tax based on their operating revenue. KDHE then combines that hospital tax revenue collected under that program with federal matching funds to increase reimbursement rates to healthcare providers. So a provider's total reimbursement rate is a combination of a standard rate for providing services plus a rate increase called an add-on percentage. And that add-on percentage is done in 2 ways. So for hospitals, the add-on percentage is 23.1% for inpatient services and 25.8% for outpatient Medicaid services. So for example, hospital that provides an outpatient service with a $100 reimbursement rate would receive that rate plus an additional $25.80. For non-hospital providers like doctors or surgeons, dentists, the add-on percentage varies by service. The average percentage across all the services is intended to be 25.8%. Healthcare providers use a procedure code to report what service they provide, and the state's MCOs reimburse the provider the amount for that code. So we reviewed non-hospital Medicaid reimbursement data for 2019 that was provided to us by KDHE. In 2019, the Medicaid program paid a total of $159.4 million across almost 900 procedure codes to non-hospital providers for Medicaid services. So the figure on page 4, I'm going to talk about those services next. So that figure shows the 20 non-hospital procedures that accounted for the most reimbursements. So you can see at the top of the figure, at the bottom of the figure, the top 20 accounted for 74% of the total payments. And the top 20 codes included things like doctor's office visits, immunizations, and physical therapy. We also looked at the add-on percentage for those 20 procedure codes. And the figure on page 6 shows the add-on percentages and the base rates for those 20 procedures that accounted for the most non-hospital reimbursements. So as you can see in the figure, the add-on percentages varied significantly across those 20 codes. So the add-on percentage for delivering a baby was 4.2%. but the add-on for an office visit to an ophthalmologist was almost 111%. KDHE officials told us the add-on percentages were set in 2006 by actuaries and approved by the Hcap panel, and that they haven't been changed since. In 2006, the intent was for non-hospital add-ons to average 25.8% across all the services. However, we estimated the average was 49% in 2019. This is likely because the services that have higher add-on percentages were used more than originally predicted. So question 2 starts on page 7. The question was, does KDHE adequately monitor and report Hcap expenditures and revenues? The short answer to that question is that Kansas's Medicaid system has made it difficult for KDHE to adequately monitor and report Hcap expenditures and revenues. The longer answer here is that state law requires Hcap to operate in 2 specific ways. So first, law requires hospital assessment revenues to be dispersed in specific proportions. Assessment revenues include the taxes collected from the hospitals and the associated federal matching funds. And those funds are combined and paid out to providers through increased rates. And the law requires that not less than 80% of them be distributed to hospital providers, not more than 20% to non-hospital providers, and not more than 3.2% to higher education programs. The second law explicitly requires Hcap to be state general fund neutral. However, state law only requires this change to go into effect when CMS approves certain changes to the Hcap program. And KDHE officials told us that CMS has rejected those changes because it violated the state's CanCare waiver. I should note here, though, that we were working on this audit doing field work almost a year ago, and we released it about 8 months ago. At that time, KDHE was still working with CMS to try to overcome some of these issues and try to get some changes approved. Since we released the report last May, we don't know what progress, if any, that KDHE has made. And so it is possible that changes have been made to this program since we released the audit. However, when we released the audit last May, everything in the report was accurate. It's just that some changes may have happened and we wouldn't necessarily know about them. So a little more about the findings, though. Managed care makes it difficult for KDHE to precisely monitor whether the program complies with those 2 state laws. Under CanCare, tracking expenditures is based on estimates of what portion of the MCO payments are attributed to Hcap. And this process is only backward-looking. It doesn't allow for a real-time look at the disbursement split or how much the program is spending. So as a result, the department only knows if the program complied with state law after the fact. In 2020, Hcap did not comply with either of the 2 provisions in state law. Again, those 2 provisions that we talked about, one is that the revenues must be dispersed in a specific way, and then second, that the program be general fund neutral. So based on our estimates using data provided by KDHE, the program did not meet the statutory distribution in 2020. We calculated those numbers using 2 different methods, but no matter how we calculated it, the distribution violated state law because hospitals received less than the required amount and non-hospitals received more than the required amount. For the second provision, although legislative intent is for Hcap to be state general fund neutral, we found the Hcap program still spends state general funds. We estimated total Hcap expenditures were about $30 million more than revenues in fiscal year 2020. That included about $12 million in state general funds. KDHE officials were aware that the program does not comply with state law in both of the areas that we reviewed. However, it is unlikely that KDHE can ensure compliance without changes to the program. So to comply with the statutorily required disbursement split, rates likely will need to be adjusted and then reviewed on a regular basis. This is because it's actuaries that set the add-on percentages based on how Medicaid beneficiaries used services in the past. So if usage or other conditions change in a way that the actuaries did not expect, then disbursements may not meet statutory requirements over time. To become state general fund neutral, the program must increase revenues or decrease expenditures. Without one of those two actions, it is unlikely that the program can be general fund neutral. So as of the release of this audit last May, the state had been unable to take either of those actions. Additionally, KDHE is not able to take many of the necessary actions independently. Some actions will require CMS approval. Others will require that KDHE work with the Hcap panel, and others will likely require some work with the hospitals and the MCOs to understand how any changes in the program might affect them. Finally, the Hcap fund report that we reviewed does not capture all Hcap assessment revenues and expenditures. We were unable to determine whether any KDHE report accurately reflects Hcap's total expenditures and revenues. This is because KDHE estimates what part of the money paid to MCOs is attributable to Hcap. And that estimate is based on actuarial work, and we did not review that process in this audit. We did make two recommendations out of the findings of this audit. One is to the legislature to consider whether the statutory split in the Hcap disbursements is feasible. The other to KDHE and the Hcap panel to review and adjust Medicaid reimbursement rates every few years with the goal of maintaining any statutorily required disbursement split. So that does conclude my presentation. I'd be happy to answer any questions.
Very interesting subject. Committee questions? Representative Ruiz.
Thank you, Mr. Chair. Are we not going to be renegotiating MCO contracts here pretty soon? And if yeah, I think we are. And if yes, how does this fit into that?
The MCOs, of course, they receive a capitated payment, so a certain amount per month per head. When they receive that capitated payment, which is part of the state's contract with those MCOs, part of what's kind of wrapped into that capitated amount is some amount of Hcap expenditure or money that they're going to spend on those Hcap add-on percentages. So if they're about to renegotiate those, then they probably should consider part of that capitated, how changes to Hcap in terms of the disbursement split and especially the general fund neutrality would affect those capitated payments.
Thank you, Mr. Chair.
Representative Lynn.
Thank you, Mr. Chair. You said that the purpose of the Hcap was to increase the providers back in 2004. How successful was it in 2004 in increasing those numbers, that number of providers?
We didn't look at that in this audit.
Do we have that information from back then? I'm curious to know how successful it was because, I mean, clearly we need more providers now. So I was just wondering with that. Thank you. Thank you, Mr. Chair.
Representative Clifford.
Yes, thank you, Mr. Chairman. I might follow up on Representative Lynn's comment, and the most telling thing in your report is Appendix A. And you can see the comparison between the add-on rates and the Medicare rate, and they are still significantly below. Being an ophthalmologist, of course, those 92004s or 12 and 014 attracted my attention. Of course, we have physician ophthalmologists billing those codes and non-physician optometrists billing those codes. It would be an interest of mine to know the breakout. I don't know if CMS or Medicaid provides that to you. But there's still, you would have a doctor who would see Medicaid patients, but they would have 2 appointments a month, because they'd rather see Medicare patients because of the high reimbursement. So that's what actually happens in practice. Thank you for the report. Thank you, Mr. Chairman.
Committee, further questions? I have a couple. Did we look at, in 15 and 16, when there was an audit done of Hcap, there was a problem with the reimbursement? I think in here I saw the 80-20 for providers versus the doctors, and KDHE, we were paying out a larger rate than we were supposed to, and that got us upside down back in those days. Now, is that what's continued this being upside down and not, I think it ended up being about the same amount of money, $10-12 million, when we finally caught that. So is this in addition to that, or is this the same money?
This is a different year. So the first Hcap audit, I think, was maybe 2 years prior to this audit, 2 or 3 years prior to this audit. And we did find some similar issues. They did find that the disbursements were a problem, that the disbursement split was not compliant with state law. They also found that the Hcap was using state general fund money. At that time, though, statute did not specifically require it to be state general fund neutral. So at that time, it was just the intent. After that audit, the legislature came in and then put it into statute. This program must be state general fund neutral. But the problems we saw here, we did see a couple we saw previously as well, but they looked at 2 different years. So the year that I think we looked at 2019, I think they looked at maybe 2016. So it's about the same amount of money, but it's not the same money. It's different years.
Very good. I worked with Senator Denning on this one here, that because he was appalled because of what happened in the past, that it was going to be revenue neutral. But so how do you have figures on how much Hcap brings down by the tax, by the 183? I think it was like 130 million or something like that.
I don't have those numbers off the top of my head. I believe our work papers would have those numbers, so I could provide you the number once I can get back and take a look.
Okay. Vaguely, I remember it was around that money, 115 million, something like that. Could you get that out to the committee?
Yes.
Okay. So I guess at the end, the corrective measures are up to the legislature. When we take a look at this year, would that be accurate?
There were actually 2 recommendations. So one of them is to the legislature, given how difficult it is to maintain that split, because they're always looking backwards and they never really know whether or not they're going to meet that split until after the fact. Because it is so difficult to do that, our recommendation is for the legislature to consider whether or not that split is necessary or desired. The other recommendation was to KDHE and to the Hcap panel to take a look at those add-on percentages again, and look at them on a regular basis, however often they think is necessary, but they need to be looked at on a regular basis.
And the split is between?
The split is the 80-20 split.
Between
between
doctors and
hospital providers and non-hospital providers.
Okay. Okay. That's what I thought, but I wanted to make sure. Any further questions? Well, very good. Thank you. That kind of gives us some tasks to work on. So, very good.
Thank you.
Thank you very much for being here. Committee, further questions? Heidi, thanks again. Okay. Well, that thing makes my head hurt. And it took me quite a while to figure out. Yeah. And yeah, exactly. And in fact, we do have the other provider deal that's in the works. I'd like to get this one worked out because the other one is twice as big as this one. The one that we have, we've applied for a Hcap for 3%, what is it, 3%, and it's inpatient and outpatient. So it would bring down like $300 million or something like that in federal money. And so it'd be nice to get that all worked out with the little one before we went live with the big one. So stay tuned. Further questions, committee? And committee, I misspoke earlier, and I say this all the time. So I never do anything in the legislature. So when I go to appropriations, I have to have a second to do anything like that. So when I said and Representative Donahoe correctly corrected me on that, this committee, sometimes I might take a little ownership, but it's wrong. And this committee is who does the work. And so anyway, just FYI. Thank you.